Welcome friends, I am Dr. V.K. Chauhan, homeopathic physician, and we are revising homeopathic remedy Berberis vulgaris. This is part 7, clinical correlation, and the text is taken up from Ellen's keynote, and this is a good revision for 4th BHMS students and interns. So let us go to the first PQR A, and here we find the Ellen tells us about the renal or vesical symptoms predominant in Berberis vulgaris. Pain in the small of back, very sensitive to touch in the renal region, worse when sitting and lying, from jar, from fatigue. Burning and soreness in the region of kidneys, numbness, stiffness, lameness with painful pressure in the renal and lumbar region. So this is a very complex syndromic approach where the pain picture has been given in reference to the symptoms which predominantly here are telling us about the kidney region. And if you recall, this is the upper urinary tract and lower urinary tract, both are shown here, and here when the stones are formed, whether they are formed in the calyx or if they are bigger stone, they will occupy the pelvic region of the kidney, and smaller stones, they trickle down into the ureter, and while traveling in the ureter, the typical pain radiates downwards, anteriorly, forwards, go to the thighs and testicles. Here the bladder is being shown, and trigon we can make out, and we can make out the urethra also. So we find that renal stone disease is a very common kind of a disease which affects approximately 5 to 20% of the population all over the world. And clinically speaking, this PQR1A, these features point to a collective manifestation which represents the complicated pyelonephritis associated with chronic renal stones. And this is a rare atypical presentation, and its treatment, as we know nowadays, we have got many investigations which we would like to carry out and consult the radiologist and urologist, and so a very multidisciplinary approach is very important, because if you analyze the stone, then you are going to go for the analysis of the stone, and then if you find what kind of a stone is this, so you will consult the dietitians also to chalk out a program where they can be given a diet chart who can avoid those particular things which are going to predispose the stone formation. And drinking lot of water is a cornerstone of management of the renal calculi. So those things we can look after. So let us see one by one important points which we have been encountering in the PQR1A, and similarly in the last paragraph, which is related to the renal problem only, so we have referred it is as a PQR1B. So both the symptoms are in continuation, and that tells us that stitching, cutting pain from the left kidney following course of ureter into the bladder and urethra. So tabacum is the right kidney, both sided renal stone, and right kidney is especially affected in case of lycopodium. Here the renal colic is worse on the left side, especially with reference to Berberis vulgaris. And here again the author tells us at this point, tabacum, either side. In tabacum, bilateral stone formation is there and pain is there. With urging and strangury, cantharis, urging and strangury is more or less when the bladder is affected, there is a irritation or cystitis and urgency, frequency, precipitancy of urine will be there. So it is similar to cantharis here. Rubbing sensation in the kidney is given here with comparison with medurinum, but unfortunately this particular symptom I was not been able to locate into the source book of the Allen's keynote. Source book is the Herring's Guiding Symptoms of Our Materia Medica. And there was also not a very good representation in the Clark Materia Medica, and even in Boric also I could not get that particular reference in such a way where we can emphatically say the rubbing sensation in the kidney is a very, very important symptom. However, if Allen has given it, we have to give significance amount of thought over this particular symptom. And next symptoms we find is the urine greenish, blood red with thick slimy mucus, transparent reddish or jelly-like sediment is there. This has been nicely represented in the Kent's repertory, and movement brings on increases urinary complaint is also represented very well in the Kent repertory in the form of rubrics. So let us compare. Here is the diagram which represents the anterior posterior aspect of the human torso, and here we can see the angle of the line where we have the kidneys, and the pain is in the kidneys takes place in the and ultimately if the stone travels down into the ureter, you will see anteriorly downwards and forwards it goes down to the testis, and in females it will go down to the thigh. So that is a classical representation, diagrammatic representation of Berberis stone we have here in this particular diagram. So what we see, let us recall. Again, I would like to repeat the PQR1B. This diagram points to classical pain radiation in cases of the renal calculi, and it points to left-sided renal calculi which associated cystitis and urethritis. The bladder and urethra, stitching cutting pain in the bladder and urethra points to cystitis and urethritis here. And let us go to the second part, rubbing sensation in the kidney, which we could not find as given in the Allen's keynote, could not be found over there. So we nearest to rubbing, we go to the following: inner chest and lungs, 28 Berberis, 28 chapter Berberis. In guiding symptoms of our materia medica, we find something similar representation with bubbling stitches darting into the part into a considerable depth. Means it tells us about the deeper part and lower part of the chest there is some sort of a stitches and bubbling sensation is there. We'll consult the Clark Materia Medica, and here we find that there is often a bubbling sensation in the region of kidneys. This sensation may occur elsewhere, but it is usually found here. And to correlate this particular thing again from the Boric Materia Medica, it is further confirmed in the urinary symptoms, urine with thick mucus and bright red mealy sediments, burning pains, bubbling sore sensation in the kidneys. Very direct symptom is coming up here, very direct symptom. So clinically this symptom is found in emphysematous. Emphysematous means gas forming pyelitis, or you can say emphysematous pyelonephritis. It is an infection, and this infection is because of again we will clarify this particular term. Emphysematous pyelitis is the term used to describe the presence of gas limited to the renal excretory system, and the causative organisms include E. coli and Klebsiella pneumonia and Aerobacter. Renal calculi act as a predisposing cause, and it can be diagnosed with CT scan, and it calls for a antipathic management. I mean to say the very acute kind of a thing, it should be taken up and it should be controlled as early as possible because it is an infection. And this infection can cause severe fulminating infection, so there can be septicemia and shock. And patients who are generally develop this, they are already immune compromised. Maybe the patient is elderly and suffering from diabetes. So with the same medicines, it will be a difficult proposition to treat it easily. So today we deal such patients with a great significant in terms of we attach it a significant point of view, and it can be treated urgently and effectively. Acute cases, especially such cases are acute. So PQR1B we find again urine greenish. We come to this particular D part. Urine is greenish, blood red with thick slimy mucus, transparent, reddish or jelly-like sediments. So here we find the patient with chronic obstructive jaundice, the presence of biliverdin in urine can give the green hue. This could be the one of the possibilities we have here. And urinary tract infection also can cause by the pseudomonas, can turn urine green due to the pyocyanin and the pyoverdin pigments produced by the bacterium. So this is a very important symptom, though noticed by homeopathic stalwarts long time back. Today we know the exact reason why it is happening like this. And again we go to the PQR1B. Movement brings on or increases the urinary complaint. So please remember, whenever we find that a common experience with the people who have renal calculi, they start the pain suddenly, because whenever they move, like they are traveling in a bus or somewhere where jerky movements are there, so this stone gets dislodged from its own position, and as it travels down, it shifts, it causes severe pain in the region of kidney or ureter. So friends, we go to the PQR2. Here we find the pale earthy complexion with sunken cheeks and hollow blue encircled eyes. This is a constitutional somatic physical profile of the patient of the Berberis vulgaris, but it is not going to come up initially as the patient has the stone, unless and until the patient goes, as we recall, goes into the chronic renal failure. So in chronic renal failure, the skin acts as a diagnostic window to many internal organs, including the renal system. And here you will find subtle changes in the skin may act as a clue to the underlying renal pathology. And let us go ahead with the clinical component or clinical correlation. This dermatological manifestation increase with the duration and severity of the renal disease, which we can identify as the commonest is the cirrhosis, followed by pruritus, pallor, pigmentation and cutaneous infections. Brittle nails are there, Bewes line and leukonychia. The prevalence of the skin finding was significantly more among the patient with end-stage renal disease and those undergoing dialysis. So PQR3 tells us about rheumatic and gouty complaints with disease of the urinary organs. So this is a diathesis of the Berberis vulgaris patient, where we can recall that the gout, uric acid crystals, they get deposited in the joints, they can also get deposited in the urinary tract, and they will form uric acid stones. And uric acid stones, ultimately these stones damage the kidney, will leading to secondary hypertension. Clinically, what we find, only about 10 to 20% of patients with gout develop kidney disease. It is known as uric acid nephrolithiasis. And several factors play a role, such as diet, high purine diet, fructose, sweeteners, alcohol consumption, and genetic aspect, as it has a family incidence up to 30% has been noticed. We go now to PQR4, colic from gallstones, bilious colic, followed by jaundice, clay-colored stools, fistula in ano with bilious symptoms, and itching of the parts. Let us recall, we are looking at the common bile duct, two cystic ducts we can see in the diagram, which are coming together forming the common bile duct, and here is the gallbladder we have. And common bile duct ultimately travels downwards and unites with the pancreatic duct to open into the ampulla of Vetter in the duodenum. And if at all we have the gallstones, you can see in the diagram, these smaller gallstones, they travel down to the common bile duct. Once they go down and travel into the common bile duct, and they ultimately stuck up in the common bile duct and pancreatic duct, probably you will have the obstructive jaundice, and gallstone colic followed by jaundice tells us with associated clay-colored stool means there is a obstructive jaundice. And this obstructive jaundice is a serious problem. It can give rise to pancreatitis also. So once the pancreatitis develops, it becomes a very medical emergency, you can say, but obstructive jaundice will have the severe green looking itching in the skin and all over the body and clay colored stools. So clinically, as we already been discussing, gallstone may pass through the common bile duct and cause obstruction and symptoms of biliary colic and cholangitis also. There can be superimposed infection into the bile ducts also. And larger stone can become lodged in the CBD and cause complete obstruction. So it becomes a surgical problem. It may not remain a simple symptomatic or medical problem. You have to consult a surgeon and plan out the treatment and intervention. So friends, let us go to the PQR5, the short cuff and chest complaint. Especially after operation for fistula, we have two remedies, calcarea phos and silesia. And here this is the diagram which is showing the rectum, and it is showing the anal fistula which is opening up inside the rectum, and it is also opening up in the perianal area. So let us recall and recap. It can be taken up as a symptom. This short cuff is taken up as a symptom, which is a PQR for berberis patient as a element from symptom. However, some patients get a dry and persistent cough after anesthetic. If you are going to use the anesthesia, general anesthesia, so this cough can be there. But in those days, there was, I don't doubt there was general anesthesia was available. So it is a minor complaint and may not relate to the chest infection, and however, this will subside in 1 or 2 days. So friends, thank you very much for patient listening. Thanks once again.